Miami Cancer Institute.
Okay, that's where my father was treated. That's why I'm asking.
Oh, really? Oh,
He was
We are
well, he was
officially
for
live.
London. Hi.
okay.
So
Perfect.
it will probably take a few minutes before we get everyone in here. However, I will do hit record, start
Mm-hmm.
welcoming in people as they come in. Remember that the content on this video is informational and educational purposes only and does not substitute professional medical advice or consultations with your own healthcare providers. So just remember that we are not here to be your doctors. Always seek your doctors, but we are here to help guide. And I will do a quick introduction of myself. Welcome everybody who is coming in the room. Many of you know myself and Kels. I am a stage 4 cancer survivor with 20 years in nonprofit cancer funding. That has just we started doing this, and I'm going to roll it over and hand it, let Kels do a little introduction, and then we will have our main guest, Dr. Mukherjee, get us started. Tell us a little bit about himself and why he's here tonight.
Sure. So I feel like we do this every time. We know each other so well, but that's okay. My name is Kels, or you can call me Kelsey. I work as a clinical trial educator now on behalf of a CRO, which is a clinical research organization. Our job is to facilitate patients joining clinical trials and making sure that they have the resources that they need to continue their participation. No barriers too big or small for us to handle. Prior to that, I was a clinical trial researcher. So I was patient bedside. I actually assisted in administering the medications and managing the trial and the information that we gathered from that and putting it all together in a nice big bow for the FDA to finally approve for us. I did that for well over 10 years. The last 3 years of that was in phase 1. So I've worked from the preclinical data all the way across to when we finally got things approved and you can just pick up your medicine at CVS. Doctor?
Hi, my name is Sharbajit Mukherjee. I am a medical oncologist, and I joined Baptist Health Miami Cancer Institute about a year ago. I oversee the GI Medical Oncology program. I am also a clinical trialist, so clinical trials are my passion. And I like seeing all sorts of GI cancer patients, but pancreatic cancer is something I very commonly see and something close to my heart.
Wonderful.
And
Yes.
I would just say, just to give an FYI to anyone on the live that might recognize that name, I've talked about my father before. The hospital that our physician today works at is actually where my father was treated for his cancer. So very near and dear place. I'm also from Miami, doctor. This is why he was down there. So, Carissa, go ahead and take it away. I interrupted you.
Great. Yes, so we are here to talk tonight on a special edition. We're going to be a little shorter than our usual hour. We'll only get to run half an hour tonight, but there has been a new phase 3 clinical trial breakthrough that has huge news and impact for pancreatic cancer. And lots of other GI cancers as well, but we're going to talk specifically more about pancreatic cancer tonight. Thank you guys all. I see those love taps coming in. We're already at over 4,000 likes. Oh, somebody just put something on my head. It flashed real quick. Thank you for the gifts, guys. And I'm going to hand it back over to Dr. Mukherjee to give us a little bit of information about this new, what this new breakthrough in pancreatic cancer is.
Yeah, and first of all, thank you for shining light on this, because this is really a game changer in pancreatic cancer. So the drug that we are talking about is called daraxonrasib. It's an oral RAS inhibitor. So RAS is a protein that is very commonly mutated in pancreatic cancer, and it is also a driver of pancreatic cancer. The way I explain it to my patients is think of it as a switch that is on and you can't turn it off, and that fuels the cancer cells to divide and grow. Now, when you turn it off with a targeted therapy like daraxonrasib, then you can see amazing response. So initially, it started with phase 1-2 trials, as we do with any of the drugs. But recently, we got some data from a phase 3 study called Resolute 302, and it basically showed that patients who progressed on prior chemotherapy, who took this drug, lived nearly twice as much as those who received standard chemotherapy alone. So that is something that is huge. We have never seen anything like that. All the benefits in pancreatic cancer, particularly in the refractory setting, has been incremental, but this is a huge leap. And we are waiting for the full data to be presented at ASCO annual meeting in the next couple of weeks. And then I'm sure there'll be a publication soon to be followed. But interestingly, what they also saw so far with daraxonrasib is that the side effects from this drug are very well manageable with dose reduction and supportive care medications. So something that improves your survival by that magnitude with a very manageable side effect is a real reason for hope for our patients. Now, based on these results, FDA actually initiated an expanded access program for those patients who progressed on prior lines of treatment, chemotherapy specifically. So we're still trying to understand the details of how it can actually get to our patients. But this is something that will be an important avenue to get the drug until it's fully commercialized.
Well, so it has now just entered phase 3 trials. Is that what I'm understanding? Just I know just a little let Kels kind of jump in there a little bit and help clarify too as well. What that means as far as where it is in the process when we might actually see it on the market.
Yeah. So you guys have heard me talk about this before, where when we are addressing like phase one is where medications go to die, right? If they don't do well here, if they are doing more harm than good to a patient, it doesn't matter what their scans show, the drug does not leave phase one. So to have accomplished these kind of landmark timeline points and made it to phase 3 is already huge. Phase 3 is when we're looking at a larger population at hand, right? We start very small and then slowly in a very controlled way, we expand and we open the doors a little bit more to make it more accessible to patients while still being very restrictive and very selective, right? We talked about this last week as well with the GI cancers. We have to get almost the most perfect patients possible because we want the cleanest, most clear data possible to be at our disposal. Of course, it's not always reflective of the global population. So once we do get that green light, we can either get a breakthrough, what we call breakthrough approval from the FDA, where you say, hey, this looks so good. We'll figure out the numbers later, put it in the people. Whether it's that or we go through all 4 phases, it's still very, very indicative of the fact that it is considered tolerable. So that means that I'm not doing harm in my journey to do so much good, but that it is also that we have levels. We have the ability to fluctuate the way that we give this medication so that it stays effective, even if a patient can't necessarily receive what we call that maximum therapeutic dose. And that's really where we're kind of trying to pinpoint what is that sweet spot and how much higher or lower from that sweet spot can we go before we start, unfortunately, diminuting the maximum potential of these medications. Doctor, I did want to, I popped in here. A lot of the followers like to either stay anonymous because they don't know who might be watching, or they sometimes are, kids that are dealing with this at home. Like my goddaughter has popped into these chats before to ask questions. So I did have one message come to me, which was how sure. So let me give preface. So we have talked about previously a medication space, the enfortumab vedotin, for example, that for the first time, it has people talking about this as something that we can finally get bladder cancer truly under control. Do you think that this medication has that possibility given how difficult pancreatic cancer has been to put on a leash to begin with?
Sorry, can you rephrase that question? I don't think.
So basically they're saying that pancreatic patients tend to have they kind of just cycle through drugs one after the other. Nothing really works. Given how successful this particular medication has been in the clinical trial sphere, do you think that this one might actually present a realistic opportunity for patients to be under control for prolonged periods of time?
Yes. And I have seen that firsthand. So at my previous institution, we had the study open and we had several patients who went on taking these drugs for several months, if not more than a year. So that is something that we very, very rarely see with chemotherapy. And remember, these were refractory patients. What I mean by that, that patients received prior lines of treatment. So this study not only gives hope to those patients, but also opens the door to test it in potentially earlier settings. So this particular drug is now being tested in the frontline setting and also in the resectable setting when there's a real, chance for curing these people. And this is only one drug, and there are several similar drugs targeting KRAS in different ways and different variants of KRAS. So this field is revolutionizing, and there is a real good reason to be optimistic here. But having said that, a word of caution that this is still not cure for majority of our patients, right? Eventually, what we see with any targeted therapy, that resistance develops, and then we need to figure out, what to do next, which, several investigators and companies are already doing. But this is a very realistic option for many of our patients.
I agree. And I did want to just pop in when we talk about KRAS, these are what we call oncogenes or proto-oncogenes. These are very specific genetic checkpoints that are in our DNA and our cells. Like I'm talking beyond microscopic, itty bitty bitty. When they get deregulated, so your body has these natural checkpoints where your body's naturally always checking on these. So if for some reason you develop this mutation where that checkpoint is released, that is where we're talking about a targeted therapy where these medications are working with your body to find where these deregulations have happened and essentially reenacting, because we can't reactivate it, unfortunately, but we can kind of mimic that same checkpoint to stop. We talked about before when we were explaining what metastasis is. You guys may have remembered we talked about something called cadherins, which are the connections between your cells that when that gets broken, your cells forget that they're next to each other and they keep multiplying and multiplying. You make a tumor. And we don't like that. So we make medications that can possibly remind cells of, hey, you don't have to keep growing, right? So that's the same idea that we're talking about with this KRAS. It had a job. It forgot its job. We're trying to give a medication that's going to remind your body how to act correctly. The secondary question that we had here, Doctor, this one, and I know this one's from one of our followers that's actually currently battling cancer. So she would like to know, with this kind of clinical trial, do you think that the patients will be able to continue receiving the medication once the trial concludes, if it has these good results?
Yeah, so I think that's an excellent question. So for daraxonrasib, patients who are already taking part in the clinical trial and they're benefiting, most studies, even if the trial is concluded, would allow patients to get access to the drug, right? But that's a very small number of population. Unfortunately, we see a very small percentage of eligible patients are actually enrolled in clinical trial. So the question is, even for the broader population, as I mentioned earlier, there is a pathway called FDA expanded access through which patients can possibly get access to these drugs. But it was announced only recently. We're still trying to figure out the details. But I'm, and several colleagues of mine across the country are trying to get this to our patients as fast as possible. But, unless it is commercially available, access will still be limited.
Mm-hmm. And I did want to jump in there too. We've talked about compassionate use before. There's a lot that goes behind that. I did a lot of that work. Shout out to my attendings. Because I was the one who was writing the proposals for them. But basically, we collect a lot of the data and we'll say, listen, this patient's cancer is acting like this and this and this. We have these reasons to believe that this medication is going to work. But it's unfortunately, I can't even say it's in the hand of the doctors. It's in the hands of the pharmaceutical company. It's in the hands of sometimes even the FDA to say, okay, fine, we'll let you do this. And I don't want it to sound like they're holding it close to their chest because they don't want to share. It's because we do have to balance how much good can we do. I've mentioned this before. If I, magical word C, if I cured your cancer, but I had to cut off both of your legs, take one of your arms, and you now live in the ICU, I didn't do my job. And that's the balance that we have to have with these medications, that even though your scans might look good, your liver looks horrible. And I wouldn't feel good putting someone on the transplant list just trying to cure their cancer or at least regulate their cancer and calm it down. So that is, it's the balance that we play at all the time. Doctor, my own question now, because I'm such a geek, forgive me. But with this clinical trial, is it going to, if you can disclose it, sometimes we can't disclose this stuff, but is this going to be randomized and blinded? Is it going to be more open label? How's the approach going to be in phase 3?
Right. So, the Resolute 302 study, that study is already going to be, reported at ASCO, right? But most of the other studies that are testing it in the frontline setting or in the adjuvant setting, as you know, that most phase 3 trials will be randomized, right? So that's the thing. Now, with some of the other KRAS specific drugs, they're doing randomized blinded studies, right? But as you know, that most patients will receive standard of care anyways. In addition to that, they have a chance of getting the experimental drug. That's the registrational trial. That's the path to registration. But as you know very well, that with some of the earlier studies, when it's still in the phase 1, phase 2 setting, patients are getting the real drug, and we know that there's no randomization. So it depends on the stage of the trial, phase of the trial.
An additional question. Oh, hi, everyone. I haven't even looked down here. Hi.
We're up to 18,000 likes, by the way. So love. Good job. Great guys.
I knew this would be popular. We talk about the breakthroughs all the time. So it's always nice to have one of our speakers come on and be like, this is what we're talking about. So this is a new question. And I actually haven't seen this person in a while. It is good to see you. So the question here is, pancreatic took my grandfather, and I know there's a genetic link to it. Is there something I can do? Is a clinical trial an option for me, or do I have to get diagnosed first?
That's an excellent question. And the importance of germline genetic testing cannot be overemphasized in pancreatic cancer. So every single patient who gets diagnosed with pancreatic cancer should have a germline genetic testing. And I like to explain this to my patients because there are two different things. One is to see if this cancer is potentially hereditary, if there are mutations that can be passed on to their children or grandchildren. And that has two implications. One, how their children or siblings should be screened. And the second one is there could be a potential targeted therapy available based on the results of that testing. So that's called germline genetic testing. So, and then there's also the tumor testing, which we will come to later. So to answer your question, anybody who has a family history of pancreatic cancer is at a higher risk. And there are some screening programs at specialized cancer centers where we screen those high-risk patients with endoscopic ultrasounds and MRIs with the hope to catch it early, because we know that when we catch it early, patients are not symptomatic and we catch it incidentally. Those patients typically tend to have a much better outcome and much higher chance of cure. Now, talking about your other question, whether you could be a part of clinical trial. So there are different types of clinical trial. One is a therapeutic clinical trial where you have a disease and we are testing an intervention, whether that's a device or a drug. And there's also another type of clinical trial that's called diagnostic clinical trial. So there are several studies that are looking at blood-based or non-invasive markers where patients are being screened for early detection of pancreatic cancer. So you could be eligible for those studies, specifically if you had a family history of cancer. So that is something to keep in mind.
And I wanted to jump in on that end as well. I'll give kind of a tangential example. There's a company called TrialNet that does a lot of this kind of predetermining biomarker testing related to type 1 diabetics. So this is where they're testing and they're looking for autoantibodies that will eventually, if you have them in your blood, attack those beta islet cells on your pancreas, deactivate them, and you will develop this type 1 diabetes. You'll stop creating that insulin that you need so much. It's completely, as Dr. Mukherjee was mentioning, it is completely non-interventional. We're not giving anything to the patient. The patient is giving to us. We are drawing blood. We are doing quality of life surveys. We are seeing them and taking notes on their physicals, things like that. So those are the trials that we're addressing here, that they're more almost observational. We're trying to see how you live while also taking into account your full medical record, where once you've already received the diagnosis, it's really just you, me, and your oncologist, of course, your whole team involved with that. Beforehand, though, it's when did you go to your first endocrinologist? Have you ever been to a cardio? All of this we take into account because we will eventually use that to say, hey, this is the perfect timeline that we've created. So that's the same idea with these. And I do think that there is one, at least over at the Winship Cancer Institute, over at Emory University. I know that there's one because they are testing for biomarkers for pancreatic. If you want, drop me a link afterwards and I will get that to you, or at least get you to my colleague over there. But that was a great question because I know early detections we've talked about before. Hi, Therese. The other question that we have here is also about early detection. So this is someone that I did the germline thing, and they said that it was not directly genetic, but that I still need surveillance, they put in quotation mark. What does that mean?
So, it's hard to know without the specifics, but sometimes what happens is that you don't have a mutation that is already linked to cancer, but there could be something called variant of unknown significance, where we're still trying to gather the data to see if those patients are at a higher risk. So that's one thing. And secondly, if one of your family members had pancreatic cancer, as I mentioned, that surveillance is something that is recommended, particularly at high volume centers where they have expertise.
I want to pop in a little bit of an anecdote on why they may be recommending surveillance for you as well. And I'm going to give a shout out to our colleagues at MD Anderson for their work with this. There was a flamenco dancer and singer, Isabel Pantoja from Spain. It was all over her family, pancreatic, her mom, her dad, her both grandparents on both sides. I mean, we didn't need any fancy testing to know that this was very likely genetic. And she was very afraid of being diagnosed. So she would actually fly from Spain to Texas to go to MD Anderson and get this testing done. Now, I'm talking about a while ago. This was the 70s and 80s. We have advanced leaps and bounds since then. However, even with this very deliberate, intentional screening, because of her history, between one negative scan and her next appointment, when it was discovered, it was already stage 4. So this is likely, this pattern that we see with pancreatic is very likely why you're still being recommended for this surveillance. It's just so that someone's like Big Brother, like right there watching you. Because we have to get in there as soon as possible. We want to get in front of it as soon as we can. It's kind of a horse at a rodeo that doesn't have someone riding on it, right? We want to get someone on top of you, under control, and immediately do a biopsy. Let's sequence this. What does it look like? And right there, start everything, because if you haven't done all of that and suddenly you're getting that diagnosis, we're already behind. And we want to give you the best outlook. And we want to also make sure that what your outlook is also what works best for you, right? If I start talking about what your goals are and you're like, I want to see my daughter get married in 2 years, I need to make sure that I can provide to you a treatment plan that gets you to that 2-year mark as comfortably and efficiently as possible too.
I'm going to just jump in here with a little bit of background, breaking this down a little bit more for people who don't understand pancreatic cancer and why it goes undetected until late stages, and why it spreads so fast is that your pancreas actually wraps directly around a nerve bundle and major blood vessels set. So when the tumors form, they're usually wrapped around this nerve and set of blood vessels, which makes it very easy for it to jump right into your blood and move to other spots before it even causes any signs. So it is that surveillance at that point, because a lot of pancreatic cancer is not diagnosed until late stages because of those reasons.
I was going to say, I can actually, my husband is to my left. His grandfather passed pancreatic. I guess Rob is there. This is a tender spot for him because, babe, if you don't mind announcing to everyone, from diagnosis to when your grandfather passed, how long did he have? About 6 months. About 6, and that was with treatment, correct?
Yes.
So, and this is someone whose wife was a nurse. You know, she would have picked up on anything from his appetite changing, and even her, this was the shock of a life to be like, what? You know, so not to put the fear of God in you, I'm not trying to do that, but it is just, I don't want you to feel like the doctors are overreacting when they said that word surveillance to you. It's just because I would rather overreact and just be like, hey, you've been on surveillance for 3 years. How you doing? You know, I'd rather that be the conversation we have in clinic as opposed to me coming in with a consent form because I need to put you on a treatment. Oh, just kidding. A new question. Hi, friend. Okay, let me see if I can summarize this. So the question here is, are you allowed to do normal, I'm assuming by normal you mean standard of care. Are you allowed to do standard of care therapy and a clinical trial, or do you have to choose one?
That's an excellent question that I get asked like almost every day in clinic when I present both options. So the short answer to that, you are usually supposed to choose one or another. Most clinical trials would want you to participate on the trial only, because if you do both, then we don't really know if the trial drug or the intervention is effective, right? Having said that, sometimes what we see that patients are diagnosed and there's an urgency to start treatment. So there are some clinical trials that will allow you to get maybe 1 or 2 standard of care treatments as we prepare you for the clinical trial. But usually, once you enroll in the clinical trial, you do the trial.
I did want to pop in there because I will say that to arm approach, if you do choose the standard of care route and then decide, like we're talking about here, there is what we call a washout period. What washout means is I need to like clean your body from whatever you did, for the same reason as Dr. McCurdy just mentioned. I need to know that whatever's happening to you when I take those really pretty scans, that it was just that investigational product, that clinical trial drug. So it is about 30 days, and that can give a lot of people a lot of anxiety. So we understand when you say, listen, I can't do 30 days, dude. Like my cancer doesn't care. I need to do standard of care. Totally fine. It's standard of care and approved because it works, and we know that. Now, that being said, when we make these clinical trials, so the question that I actually asked our guest here earlier about whether it was randomized, what you're going to do, a lot of these clinical trials will mix what standard of care is, because we have to treat you, right? It would be completely unethical to say like one medication is water and the other one is a drug. We will never do that. We're always comparing to something, and the something has to be what's approved. So a lot of times you're getting some form of the standard of care, and then the other option in the clinical trial is standard of care plus. So you're always getting treated. It's just a question of how much extra oomph are we sticking in there. Thank you for that question. That's a very good question. I don't have anything else. I'm looking at like all of my screens that are active.
Yeah, I was gonna say I'm going through the list of questions as well. Are there any symptoms or warning signs with pancreatic cancer that we could at least, as we've already talked about, there's a reason it goes undiagnosed to late stages, but
right. So there are certain symptoms that appear when the pancreatic cancer is advanced, and one of them is unexplained weight loss. So sometimes patients will notice unexplained weight loss going on for several weeks to months, and we can't figure out why. So the other common problem is jaundice. So sometimes when the cancer is growing at the head of the pancreas, it can compress your bile duct and it impairs the flow of the bile. So patients get jaundiced, their skin or eyes get yellow, dark urine, greasy stools. So that is something that is commonly seen. Pain is another common symptoms that we sometimes see. Another important thing that is sometimes missed is if a patient has a new onset diabetes or worsening diabetes that can't be explained otherwise, that could be a warning sign for pancreatic cancer. Now, these symptoms can happen for several other reasons. So most of the time when these symptoms happen, they're not because of pancreatic cancer, something else. But we as cancer doctors, whenever we hear these symptoms, there's a knee-jerk reaction. Let's scan you, let's do some blood tests and make sure that this is not pancreatic cancer. So those are some of the things that we very commonly see.
A very valid follow up to that is, can you ever be too sick for a clinical trial? And I'm going to break your heart here. The answer is yes. I mentioned this before. We do want someone I want someone in a clinical trial that if I look at them, I wouldn't be able to know that they have cancer. And I know that seems really, really unfair. But the idea, our approach is that I have to give these drugs the best opportunity to do their job as unfazed as possible. And in order to do that, you cannot have very severe jaundice because I need your liver to be able to metabolize and process this medication. You can't have polyps developing in your kidneys because I need them to filter your blood and keep this going. I can't have really bad neuropathy in your hands because I might make it worse. All of these things we have to take into consideration. Again, it always goes back to that same principle. Am I doing more harm than good? And I know that seems really unfair because, as Dr. Mercucci has mentioned, he's like, this is literally part of the disease. And mind you, they can be very lenient, especially in the phase 1 when we're starting this process. They can be very lenient and be like, listen, do you have hemoglobin? Like, is your blood red? You can join. Versus when you get to phase 3, now it's like your hemoglobin needs to be at least 10, right? We start adding these additional roadblocks. And I don't want you to think that it's because we don't want to treat the patients. It's because I might have the key to giving someone 6 more months of life. And if I didn't select my patients correctly enough, that may never make it to phase 3 or 4 or the public. Did you want to add anything, doctor?
No, I think you explained it, very, very well. Yeah, I don't have anything else to add. Yeah.
One quick follow-up. Do
Go
you
ahead.
have any early
Yep.
detection or screening tools that are coming, that are new or coming into market, or that we're looking at? Because I know, as we've talked about it, it is hard to catch.
Right. No, there are, and I would say that they're still in development. So, the current standard surveillance tools would be endoscopic ultrasound and MRI, but there are several blood-based tests that are being tested, and also AI is revolutionizing everything, including early detection. So there are some studies that showed that AI-based approach could detect incidental pancreatic cancers that are otherwise missed. So there are prospective studies that are looking into that. But there are new things coming, both radiography-based as well as blood-based, and we are hopeful about the future.
I was going to say, as soon as you said that, I thought about it. I'm like, it was a nanoparticle. It just popped into my head. So yes, there is. Don't ask me who it was, and I apologize if you are watching. I promise I read your paper and I just didn't pay attention enough. I'm sorry, but it is they're calling it a tumor particle detection. So it's using nanoparticle technology. Shout out to the physics majors out there, because I hated physics, but it's these nanoparticles that are actually able to, on a very, again, beyond microscopic, right? Nanoscopic, if you will. They're able to, and it was insane. The paperwork was saying like 80% sensitivity, being able to early detect these same biomarkers, these same patterns that we're talking about, that when they get out of control, you seemingly overnight, you have a tumor that we got to talk about. So I have to do my own homework now, but that sensitivity, that's the important part, right? Because if you have 100% accuracy, but you're not sensitive, which means it doesn't happen often, that's not useful. We need good accuracy and good incidence. And this one was like right up there in the 90s for its accuracy and in the upper 80s for its detection capacity. So yes, there's definitely things in the pipeline, incredibly, incredibly encouraging, again, in the light of a particular diagnosis that is not, can put the fear of God in you. Pancreatic is not, she's not kind, unfortunately. Yeah. So there's definitely hope in there.
And that's why this treatment has been such a huge breakthrough, because there has not been a lot of hope for pancreatic cancer. It has been so common. It's usually so late detected. My throwback to where I started was the University of Virginia Clinical Cancer Center, where we built the Emily Kirk Clinical Cancer Center, who, yes, died of pancreatic cancer because there were no options. And so I know one of her passions was making sure that clinical trials were available more easily across the U.S. So Thank you both for being here tonight. I know we're kind of running on time, a little bit past 7:30 here. So if there's any last questions or things that anyone wants to wrap up with, I'm also going to give a throw out to remember GLOW-Oncology is why we are here tonight. You can find our tag at the bottom of the screen. Also, our lovely Kels Liven, her tag is down there as well. Make sure that you give us both a follow, and we will turn it back over and let our medical professionals wrap things up. And we are, by the way, 32,000 likes and running tonight. Thank you.
My favorite number, 32. I did want to say I knew that this one would be active. I'm not surprised. So thank you all for joining and for all your questions. And of course, we record these so that you guys can watch later because I know a lot of you are families. But as always, I leave you guys with the same piece of advice: ask questions. There's no such thing as a dumb question, especially in the infinite depths that is oncology. I love to geek out, and it's very little things that will make me do so. Like my colleague Katie that I had here as well. She's the supervisor for the GI oncology team research squad over at Winship as well. It's the same thing. We live for the questions because it tells me that you are as ready to battle this as I am. So thank you guys for spending the evening with us. Thank you, Doctor, for joining us as well. And I'll see you at ASCO if you're going to be there.
Yes, we will be meeting with Dr. Mukherjee at ASCO. Kelsey and I will see you there along with Andrea. We're not going to go too much more onto what that is on a public level, but we are, of course, in private contact. Kelsey and I have to watch things a little publicly.
Yeah, those dang NDAs will catch you. But without further ado, you guys, we're going to go ahead and sign off. Thank you again for the time, Doctor. And everyone, if you have follow-up questions, follow them up with us. We will relay them over if they're directed to our guest here, or if we can facilitate your access to resources as well.
Yes.
Otherwise, have a good evening.
Absolutely. Thank you, everyone, for being here. Have a great night.
Thank you.
Bye-bye.